Thank you all for great presentations. Some of these are practice-changing. I'm Chandra Balani, Chief Science Officer of the ISLC, and with me is Dr. Murray Wines, Chief Scientific Advisor of Scientific Affairs at ISLC. And we'll be moderating the session. A number of questions have been given to us from all over the world, and we'll be sorting them out in the next few minutes. The first question is for Dr. Suboy. Dr. Suboy, Dr. Corey Langer is asking, in the absence of survival data from a DARA study, is it justified to give osimertinib in all patients who have undergone resection for early stage disease? Dr. Suboy.
Yeah, actually, right now is the DFS is quite difference between osimertinib and placebo. I think that this huge difference is promising for the survival effect to the patient for the patient. So I explained to the patient that's the difference for the DFS. But actually, scientifically, we would like to know the overall survival. How about the cervical shape? I mean, so crossover or difference changed.
I think the hazard ratio for disease-free survival is impressive. I think we need to talk to all our patients, especially those with stage 2 and 3A disease, whether they would be willing to take it despite some toxicity, though not much.
Yeah, and also, Chandra, and also I'd like to enhance to the relapse site for especially the CNS. I will present that topic in the ESMO meeting, but so at that time I can explain it for such a recurrence pattern. So very important issues.
Great. There is another question which is also on the same lines, but I'll ask Dr. Murray Wines to answer. Is MPR a valid surrogate endpoint for survival in patients who are undergoing neoadjuvant immunotherapy or immunochemotherapy? We have this as a pillar of our Lung Ambition Alliance, and Murray is leading that section. So Murray, maybe you can answer that question.
Yes, thank you, Dr. Balani. And before that, I just want to say what a wonderful presentations we've had this morning. Grateful for all those who have participated, and it's so great to see such wonderful science even in the virtual setting. Related to this question that Dr. Balani has posed, for lung cancer, I don't think we can quite answer that yet. The early phase trials have shown that a number of patients receiving IO or IO plus chemo do have an MPR, but whether or not that's a valid endpoint, we don't really know yet. And that's why we're conducting this ISLC initiative to look at that. It's a 3-part approach. We've published a paper on some standards on how to go about scoring. We're conducting an inter-observer study at the moment. And then we will actually take the data from the large clinical trials and compare the pathologic response to outcomes to see if it is truly a valid marker. So please join us in this initiative if you can.
Marina, the next question is for you. As you now have funding from the ISLC and endorsement by various societies, do you think that has helped increase the accrual to the registry for your TerraVol study?
So I think that it was very helpful, and I think that it was very nice to see all the Lung Cancer Society very united to provide the data for COVID-19 and lung cancer. So, but I think that the international societies were very, very important to create this big effort. So I'm very grateful to ISLC for this.
Great, thank you. Murray has the next question for you also.
Right, yes. This question came in from the audience. So Dr. Garasino, what is your opinion on the role of steroids in the treatment of COVID-19 patients with thoracic malignancies?
Yeah, so I think that we really don't know what is the effect of steroids. What we could provide for with the preliminary data from 400 patients is that steroids in the beginning have a negative impact on the outcome of COVID-19. But this was also adjusted to the multivariate analysis, was positive. We know also that steroids have a very important they are very important for the treatment of COVID-19. So we do not know if they represent patients with poor prognosis and they are just a negative prognostic factor. They have a real detrimental impact factor on the COVID-19 disease.
Right. So there may be a differential effect for those with and without a thoracic malignancy with the use of steroids?
Yeah, it is possible. So my opinion is that we have to deliver steroids when it is important for the patients, because data suggests a negative impact in the beginning, but we do not know if this is correlated to the negative performance status or it is a true negative effect of steroids.
Thank you. Dr. Bolani, back to you.
Dr. Jangli, there's a question for you, and they're asking whether you would give the combination of Sinti with chemotherapy in all patients who have greater than 50% PD-L1 positivity, or would you just select certain patients who have bulky disease?
Okay, thank you for the question. I think it's right now, according to our study result, even the PD-L1 negative population, you still see the PFS benefit compared with the chemotherapy alone. So right now, I think it's that we do not have any evidence to select some special population for the patient. But of course, I think if a patient with PD-L1 high overexpression, you can see here, you can see in our studies, the hazard ratio is much higher compared with the PD-L1 negative population. So definitely we will select the PD-L1 overexpression higher population to the bulky disease to the combination treatment. I think this is the only answer we can give right now.
Misako, you want to comment on that? Please unmute your mouth.
Sure. So I think that is an excellent question. And I did in my presentation ask the audience about what the preferred regimen would be in both PD-L1 1 to 49% and PD-L1 more than 50% or at 50%. And to be really honest with everyone, I would like to admit that there was a lot of background information missing from that question. Basically, what I think is important is not just the science, not just the progression-free survival, not just the response rates, but also patient preference, their age, medical comorbidities, what they do for work. And I think all of that has to be taken into account. So definitely the combination of Sinti plus chemotherapy appears to be a promising regimen for both patients, whether you have high PD-L1 or if your PD-L1 is less than 50%. But I think it's not just the data. We have to put into context everything else as well.
Great, thank you. The next question, Murray, you want to take this on PD-L1?
Right. Dr. Zhang, this is another question that came in from a couple audience members. And they're asking what PD-L1 antibody and assay platform was used for the Orient 11 study.
Okay, I think it's according to our, this is the, I think we used the 22C3 mono antibody as a evaluation of the PD-L1 overexpression, which is similar with the PEMBO study.
Thank you. Dr. Bolani, shall I ask Ms. Freeman-Daly a question?
Yeah, sure, absolutely. That's her question.
Yes. Good morning, Janet. Many times PS2 patients are not included in clinical trials. So how do you think we might go about removing this barrier?
I don't see Janet. I think a lot of patients do have ECOG performance status of 2, and are usually excluded from most of these trials. I think we should try to be more inclusive because we see the benefits, especially with targeted therapies, which is phenomenal and it occurs very early. So I think we should try to include ECOG performance status 2 patients in some of our studies. Maybe we can ask Leora. Leora, what do you think?
Yeah, I agree. I mean, I think a lot of the time as companies, they're worried about their drugs not doing as well if they're looked at in patients who have less robust performance status. But the reality is in clinic, many of those patients we classify as ECOG 1 for studies are often ECOG 1 minus and close to ECOG 2. And being a little bit more inclusive in who we include in the studies will give us more confidence in administering some of these drugs to our patients.
So there's another question for you, Leora, that with now availability of multiple drugs in the first-line setting for ALK-positive patients, how do you really prioritize and choose that until Alice Shaw's study becomes available?
Sure. So, I think there are a couple of factors that we should consider. Number one is patient compliance. These drugs are a little bit different. Alectinib is, in the US, is 600 twice a day. That's 4 pills twice a day that patients have to swallow. Brigatinib is once a day, and sartanib is once a day. Lorlatinib is once a day, assuming that data is positive. Well, we know the data is positive. We just haven't seen it. And so it's a little bit easier if you have to remember to take your drugs once a day. The other is the toxicity profile, which Dr. Lovely pointed out. These drugs have slightly different toxicity profiles. And so we actually had a study years ago that we looked at patients' willingness to comply with long-term therapies based on toxicities, and the GI toxicities can become an issue, especially for patients who are on these drugs for years. Grade 1, 2 nausea, while we say, oh, well, that's not a big deal because it's not a grade 3 toxicity, can become a big deal over time. Anyone who has had a GI bug for one day can attest to that. And I think the final factor, which we don't talk about enough, is cost. We have multiple drugs now in the same arena. And we've seen the same thing in hepatitis C, and the cost of those drugs came down rather than pricing the next drug to meet the market price of the other drugs. And somewhere one of these drugs is going to come in at a lower cost, and with similar efficacy and lower cost, that should be an important factor in how we think about what we're going to prescribe for our patients.
Thank you. Murray, you want to take the next question on resistance, which has just come in?
Sure. This question, I guess, could be for either Drs. Horn or Lovely. And Dr. Lovely kind of touched on it with the ALK master protocol. Maybe we have to wait for that data. But the question is, in the resistance setting without TKIs, is it time to start routinely making decisions on what next TKI to potentially give based on the resistance mutations detected at recurrence? So maybe start with Dr. Lovely.
So hi, everyone. Thank you again for joining us today. It's really a pleasure to be here. I would say this is a wonderful question that we really struggle with as a field in general. The later generation ALK TKIs have specifically been designed to overcome many of the resistance mutations that we initially observed with crizotinib. However, there are unique vulnerabilities to each of these ALK TKIs based on the structure and how the drug binds. So I think without prospective clinical trial data, which is what we're hoping to get from the ALK master protocol, this is going to be a very difficult question to address. But the good news is there's multiple different mutations, greater than 20 different positions where ALK can be mutated. But most of the drugs that we have right now can overcome the majority of mutations. The one that we particularly worry about is this G1202R, and we anxiously await additional data in prospective cohorts to see how various ALK TKIs can overcome that particular mutation, which seems to emerge at the highest frequency as patients go through multiple lines of therapy.
Maybe I can a little bit by asking the question, if somebody gets alectinib up front, what's the next line of treatment in most of those patients? Is it based on the resistance mutations or based on the variants of ALK?
In my opinion, it would be based on right now, we don't actually need to prescribe lorlatinib in this case, where we have the most amount of data of lorlatinib after second generation ALK TKI resistance. Lorlatinib is approved irrespective of the specific ALK kinase domain mutation. However, I do think it is important for us to strategically deliver these drugs in a more precise way. Again, I think prospective trials would be helpful in this arena. while I think the variant is a very interesting question, and there are certainly numerous preclinical studies showing that the variant could be important, there are also retrospective trials or retrospective studies, and Ross Kamich published one in Journal of Thoracic Oncology looking at data saying that the variant may not affect outcome. And so I think the data and the jury are still out in regards to how the variant affects outcome. For sure, the specific kinase domain mutation will affect efficacy, particularly with earlier generation ALK TKIs.
Thank you. Dr. Bass, there's a question for you. Lima Vladimir is asking if there was analysis of patients using gene expression to classify malignant pleural mesothelioma samples. Was there any gene expression analysis done on the samples that were collected?
So on the samples that are collected, we do not yet have these analyses run, but this will be part of future studies.
I see. And in addition, there is a question that the sarcomatoid group did very well with the non-chemotherapy combination of nivo and ipi. And with the epithelial, you saw only very modest difference, though the survival was, there was a benefit in survival in all subgroups. Would you just give this to sarcomatoid patients or all?
Okay, if you look at the data, you can have a benefit from the ipi and nivo in all comers. So you don't have to worry whether it's epithelioid or non-epithelioid. There is a benefit and also a difference in the tail, the response, the duration. So the effect is mostly pronounced at the sarcomatoid, but you still have a lot of patients. If we look at the 2-year interim of analysis point, that these patients are censored. So we do not know if this hazard ratio is even going in a better direction.
Thank you. Dean, you want to comment on that?
I'll just comment briefly about the first question on gene expression. I think that's well worth doing. Certainly the EMT that I talked about is something that is a smooth gradient across all histological subtypes. And so there may be some, of course, epithelioid patients with EMT that might be benefiting that bit more from the ipi-nivo.
So Dr. Liu is asking, once neo-AP becomes available, should we be using PD-L1 expression to select our patients? Paul or Dean?
To use PD-L1 expression?
Yeah, that's what he's saying.
Well, the problem with the PD-L1 expression, it's still exploratory, and we also did not stratify in the study for it. So I'm a bit reluctant to say that this is prime time to use it at the moment. For the ipi-nivo, the effect of the experimental arm, the nivo-ipi was certainly good. You don't have to worry about that. It was more a negative predictor for the chemotherapy.
Thank you.
Follow-up question for that, Dr. Bolani, I guess, would be: are there any challenges to scoring PD-L1 expression in mesotheliomas? Or is there differences in lung cancer? Do we know that those same cutoffs apply?
Yeah, well, there's a lot of conflicting data about the PD-L1 expression. We know that it's more prevalent in the non-epithelioid type. And of course, quite often we have only small biopsies in mesothelioma where you can maybe miss the PD-L1 expression. So as in lung cancer, there's a limitation to this biomarker. And I think it's even stronger in mesothelioma. Especially when some centers do make the diagnosis on cytology alone.
We'll take one more question. Somebody is asking whether there is a role of postoperative radiation therapy in patients who have been treated with osimertinib and have stage 3A disease. Dr. Suba, you want to take that? You are muted.
Sorry. Actually, I have read that this is Japanese special situation. I think that radiation and TKI is combination will be happen to the ILD, post-pneumonitis. So and also ILD. So I think depends on the situation. If the surgical margin is very close to the tumor, so so probably port will be considered. But in the case, depends on the recurrence pattern by osimertinib treatment. So if the local treatment is controlled by the osimertinib, it is not necessary to use the port. So depends on the recurrence pattern in the osimertinib arm from ADORA results.
Thank you, Dr. Suboy. In the interest of time, I guess we'll end the session on discussion here. Thank you all for, again, great presentations. Some of these are practice changing. And I will hand over the stage to the chairs, Dr. Yilong Wu.
Thank you, Dr. Brani. First, as the chair of the World Conference on Lung Cancer 2020, I would like to thank all the speakers, oral presenters, and their discussion for their excellent talk. Your work has enriched this meeting. Thank you for attending the first President Symposium. If you are not an IARC member already, I encourage you to become the part of this global community. You will be joined more than 8,000 lung and thoracic cancer specialists from all the disciplines and more than 100 countries. I look forward to see you during the World Lung Cancer 2020 first meeting in January. Dr. Shou, please.
Thank you, Dr. Wu. On behalf of the co-presidents, we would like to thank the local organizing committee and the program committee for your work on the WCLC 2020, and our sincere thanks to the sponsors for the continued support as we navigate the challenges of COVID-19. As you know, the IASLC has offered this meeting free of charge, and we hope you will consider donating to the International Lung Cancer Foundation to support research fellowships. Dr. Tan.
Thank you, Ross. Again, thank you all presenters and delegates today. We really appreciate your participation and opportunity to engage everyone again. Our commitment to progress must continue, so do submit your abstracts to upcoming ISLC meetings, including the full online WCLC meeting in January next year between 28th to 31st. We look forward to seeing you during these virtual meetings as we continue to adapt and innovate on new ways to connect with each other. So this concludes the virtual presidential symposium. Thank you, everybody. Please stay safe and healthy, and we hope to see you all soon. Take care. Good night, good evening, good afternoon, every day.